Can you see them, Trudy?
Yep.
Yeah, brilliant. Okay, so good morning, everybody. I'm absolutely delighted to be invited to this study day today. My name is Melanie Nana, and I'm a final year endocrinology and general medicine registrar, training in obstetric medicine, and currently doing my PhD focused on the management of hyperemesis. So I'll go through the talk. I'm very happy to take any questions at the end. So, as you will all know, many women will vomit in pregnancy. So 80 to 90% of women will experience some form of nausea and vomiting of pregnancy. However, there are up to 3.6% of the pregnant population that will have a severe form of this disease, which we call hyperemesis gravidarum. And of these women with hyperemesis gravidarum, 1 in 5 of them will vomit throughout their entire pregnancy. So historically, we considered this a disease of the first trimester. Some women would be unfortunate enough to have symptoms into the second, but it's now well recognized that if you're on the severe end of the spectrum, it's likely that you're going to have symptoms, well, 1 in 5, 20%, throughout the whole pregnancy, which means that when we're treating these women, we need to think that they might need anti-sickness medications for the whole duration of pregnancy. In 2021, a new definition was confirmed for this disease, and it came from a group in Amsterdam who got together with international colleagues to try and determine if we can find a definition that will allow us to give good holistic care. And this is the definition that they came to. So if you have symptoms before 16 weeks, nausea and vomiting, one of which must be severe, that is severe enough to limit your ability to eat or drink normally, or to limit your activities of daily living, then we can consider that patient has hyperemesis. The benefits of this definition is that we hope that it'll give more women access to good care, but also for those of us who are doing research in the field, it gives us a definition that we can all play by. So we're reporting outcomes on the same group of patients. So in terms of what causes hyperemesis, in the textbooks and in our university days, we learned about the role of HCG, which is a pregnancy hormone, which goes up in early pregnancy. It gives you your positive pregnancy test. And it makes sense that this hormone will contribute towards nausea and vomiting of pregnancy because it peaks at about 12 weeks gestation, which is the time that the symptoms start to peak. However, it's evolved over time to see that maybe this isn't the only player in the cause of this disease. And in the news, you might have seen over the last sort of 18 months, the role of this new hormone, GDF15, which is considered to also play a role. It's a placental and appetite hormone gene, and this is how it works. So this is the placenta, and it's GDF15, this hormone is produced in large amounts by the placenta. It binds this GFRAL receptor, which is in the area postrema of the brain, which is what we call the nausea and vomiting center of the brain. And when this GDF15 binds the GFRAL receptor, it causes vomiting and appetite suppression. And a lot of work has been done now, which suggests that this may be one of the causes of this disease. Now, this is the same part of the brain that's affected by chemotherapy in patients who are receiving it, which causes the nausea and vomiting that you get with chemotherapy. So I think lots of women that I've seen with this disease over the last few years have said, I'm vomiting, I feel nauseated, I really feel like I'm dying. And this might give us some insight into why these patients feel like those patients who are receiving chemotherapy, just really, really rotten. So when it comes to clinical assessment, we published the Royal College of Obs and Gynae guidelines in February this year, and we tried to come up with some algorithms as to how you would initially clinically assess these women. And this at the top here was what we thought was appropriate for all patients at their first sort of encounter with nausea and vomiting of pregnancy. So we need to confirm the diagnosis. And in order to do this, we take a history, examine the patient. And if they give a good history of nausea and vomiting from early in the first pregnancy, perhaps they've had it in a previous pregnancy as well, we want to do some simple investigations just to make sure there's nothing else going on that could be causing the symptoms. These include a urine dipstick, and I'm going to come on to the reason that this isn't to look at ketones, this is to look at nitrites and leukocytes, because we know that patients who have water infections or UTIs are more likely you can have symptoms of nausea and vomiting with that. We're recommending a full blood count, glucose, and renal function. This is because signs of infection would be evident in the full blood count, high glucose levels, which could cause nausea and vomiting, or in cases of diabetic ketoacidosis, could cause these symptoms. And abnormal renal function can also contribute towards nausea and vomiting. The ultrasound is to look to see whether there's a single ongoing viable pregnancy and to see whether there's one baby, two baby, or more. because we know that multifetal pregnancies are increased with increased risk of hyperemesis. So this is the expectation in all patients presenting for the first time with hyperemesis. In those patients who you give treatment to, but they don't resolve as you might expect they would, then we consider that we should do these additional tests in what we call refractory cases. And the reason that we do these additional tests is because there could be other underlying causes. So we would expect that most patients with a diagnosis of simple nausea and vomiting of pregnancy or more severe hyperemesis gravidarum, if they're treated with 1, 2, or some need 3 anti-sickness medications, you expect them to get better. But some of the patients that we see don't quite have the right story. So, for example, a lady comes in and says, I've had nausea and vomiting of pregnancy. I've never had this in a previous pregnancy before. I've had 2 previous normal pregnancies which have had no vomiting in. I've lost 1.5 stones worth of weight. I've got some epigastric pain. So in those patients, they raise some red flags that make us think, is there something else going on? And there's a couple of cases that we've found in patients like that who we've ended up doing an endoscopy and found that they've had a gastric or a stomach cancer. So I think these cases are rare, but we need to think about them in patients that aren't responding as they should do. Simple tests that we can do to screen for these other causes that are written here in this differential diagnosis are thyroid function tests, liver function tests, calcium phosphate, amylase, and I put here venous blood gas. An arterial blood gas would also be fine, but to look for metabolic causes. Now, I'm going to go through not all of these systemic effects of hyperemesis, but some of them, because I think if we're going to be able to provide good care for these patients, we have to understand all the ways that hyperemesis can affect the multiple systems of the body. So the first that I've got up here is biochemical thyrotoxicosis. And I just want to make you aware of this because you may be called about a patient who's had some thyroid function tests and they're abnormal. But we know that in patients with severe vomiting in pregnancy, that the thyroid function tests become abnormal in early pregnancy. So you get what we call a biochemical thyrotoxicosis. The thyroxine level goes up and the stimulating hormone goes down. So in most cases, this will be treatable if you treat the underlying disease. So I think it's very reasonable to give those to the clinician managing the patient to determine whether they've got other symptoms of thyroid disease that might not be related to hyperemesis. So, for example, women complain of eyes that are protruding, tremor, diarrhea. They might have a family history. But in most cases, this will get better with treatment of the disease. The other complication that I want to talk about is gastrointestinal symptoms. So we know that in up to 60% of women who have hyperemesis, they will have some form of reflux disease. This is common in pregnancy anyway, but if you imagine that you're vomiting and you have reflux, this might make the disease more uncomfortable. We're able to use proton pump inhibitors. We usually use omeprazole or lansoprazole in pregnancy. But we also need to look out for those red flag features that I mentioned before. So weight loss, women who feel like perhaps they've got something sticking in their chest and not responding to treatment, because those women should be referred to a gastroenterologist or the obstetrician or obstetric medicine team to investigate for other malignant causes. The next thing I want to talk about is liver enzyme disturbance. And the reason that we started to think about liver enzyme disturbance in the context of hyperemesis is because we were asked to write the European guideline for liver disease in pregnancy. And one of the hepatologists said that they as hepatology specialists often get called about patients who've got quite significantly abnormal liver function tests in the context of hyperemesis. And when we went to the literature, we found that up to 40 to 50% of women who have HG will have a rise in their ALT, so the alanine transaminase, ALP, bilirubin, or amylase. And this case study here that you can see, this isn't one of my case studies, it was published in the literature, shows that this is a lady who's come in with severe hyperemesis. This is her ALT. It goes up to as high as 1,674. She then received treatment with IV fluids and anti-sickness, and look, it comes back to normal within 30 days. We think this is because of starvation that takes a hit to the liver. So because we weren't able to find any cases in the literature where this has actually caused liver failure, we have recommended that only if the liver function test is 5 times above the normal limit, we would do further investigations to look for other underlying liver disorder, for example, hepatitis or autoimmune hepatitis. So again, a bit like the thyroid function tests, we can accept that these abnormal numbers will arise. We treat the underlying condition, we expect them to get better. The next thing I want to mention is venous thromboembolism. I know that many of you will be very familiar with screening women for the risk of VTE, but we know that those patients who have HG are at 2.5 increased risk of VTE compared to the background pregnant woman. And we recommend using the RCOG guidance to risk assess these patients. Thankfully, not many women in the UK die of this condition, but these cases do occur and these women do die occasionally, which I think in most cases can be prevented. When we look at the Embrace report, which you'll be familiar with, a confidential inquiry into all maternal deaths across the UK, we know that women can develop abnormal potassium levels if they're starved. They can get low sodium levels, and these can result in arrhythmia, central pontine myelinosis, and acute kidney injury. So arrhythmia results from abnormal heart rhythms from low or high potassium usually. Central pontine myelinosis is a disorder of the brain where if the sodium is low because a patient's become dehydrated and they come into hospital and they have it rapidly increased back to normal, the brain does not cope with that mechanism very well and it can cause brain damage. So that's why when patients come in with hyperemesis, we like to check every day what their sodium is doing and what their potassium is doing as we treat them. Acute kidney injury results from dehydration, and these are the most common causes of death in patients with HG. These are vignettes from the Embrace report that relate to hypokalemia, because I think that, you know, my impression previous to having read about these patients regularly is that, you know, we know about these patients, we know that they get low potassium and they come into hospital and we treat them, but this isn't always the case. So these are some cases where these are patients with epilepsy. So they haven't come in necessarily because of the hyperemesis, but they've come in because of seizures. One of these women with hyperemesis did not see a senior doctor for her entire 5-day admission. And we know that that is not acceptable, but it does happen. And we still didn't see any doctor 3 days prior to her death. And she had undiagnosed low potassium, which is thought to have been a cofactor in her death. And this woman was managed in a side room where she wasn't being monitored closely. So these are patients that are right under our eyes. So we need to look out for them. And if they're coming for another medical problem, we know lots of women that come into hospital these days are comorbid. Be thinking about their other symptoms. These are women who had thyroid disease. So 2 women had severe hyperemesis with marked biochemical thyrotoxicosis. One of them had come in with a potassium of 2.6 to 2.8. And this woman was tachycardic, so had a raised heart rate. She was investigated, but the low potassium was not treated, and it may have contributed to her death. So these are simple things that we can manage, but we need to look out for them first. So there is a recommendation that women with a potassium level of less than 3 should be corrected, as it may cause fatal heart rhythm disorders. So now let's talk a little bit about vernocase encephalopathy. So this results because of thiamine deficiency. So this is why we give women oral thiamine tablets or Pabrinex when they come into hospital. This disease is really difficult to pick up because it is often very slow onset, insidious. The women might complain of a little bit of confusion, they might feel a little bit unsteady, but it's associated with significant complications. So this is a review of 177 patients who have vernocase encephalopathy as a result of hyperemesis. They occurred in patients who had severe vomiting early in pregnancy, and these are the long-term consequences. So 65% will have chronic cognitive disorders, half will lose their pregnancy, and maternal death occurs in 5%. This disease can be exacerbated by using the wrong type of fluid. So in the guideline, we recommend either normal saline with potassium, or in some cases on day units, giving Hartmann's solution. What we must never use for the management of hyperemesis is dextrose solution. And the reason being that it can exacerbate this complication of vernocase encephalopathy, and it was the cause in 15% of these cases. So what can we do to try and prevent this? We need to make sure that if patients aren't eating regularly, they have thiamine supplementation. And if they come into hospital and they haven't been eating properly, we can give them Pabrinex or vitamin B complex to try and prevent these complications. As inpatients, we tend to give patients 1 bag of Pabrinex a week, roughly. It doesn't need to be every day. So the next thing that I want to talk about is the risk for the fetus and the child, because I think part of the reason that patients haven't historically received good care for hyperemesis is because we assume that it doesn't really cause any harm. So people say, it's really miserable, but it's a sign of a good ongoing pregnancy and it won't do any harm to your baby. But that's not the case. And more literature is demonstrating that. So the first thing to mention is that these babies are born small for gestational age and have evidence of fetal growth restriction. We've just done a study at King's College Hospital where we've looked at just under 900 patients with hyperemesis, and we've compared them to the pregnancy outcomes of 55,000 women who have healthy pregnancies in the background population. And in the hyperemesis group, 18% of these babies were born under the 10th centile that had severe disease. So we're not 100% sure why, but we presume that it relates to not being given good nutrition. The mum doesn't have good nutrition. They can't develop a healthy pregnancy. And so we need to really make sure that we're treating these women effectively to prevent these longer term adverse outcomes. There are also rare complications of what we call intracranial hemorrhage and grey matter heterotopia. So this is bleeding into the brain for the baby. And this is a seizure-like disorder that babies can be born with. Both of these relate to low vitamin K deficiency. So this isn't something that we routinely check in practice in the UK, but we know that if women are completely starved and they're not eating and drinking properly, that their vitamin K levels can become deficient, and this can affect the development of the brain of these babies or bleeding into the brain. In the longer term, we know that children born to women with severe disease are at a 3-fold increased risk of developing either ADHD or autism spectrum disease. And there's some suggestion that they become obese later in life. We think this is because they're starved in utero, and then they go through that period of catch-up growth, which means that they deposit more fat. So the purpose of my PhD is to try to determine what causes these long-term metabolic and neurodevelopmental outcome risks. But a lot of work is going along simultaneously to try and understand what sorts of neurodevelopmental problems they are. So this is some work that was done in North America, which showed that children born to women with severe disease were 3-fold more likely to have attention disorders, learning delay, sensory disorders, and speech and language delay. And importantly, this did not relate to the anti-sickness medications that they were taking. So when women worry that some of the anti-sickness medications are not safe, and these are medications that we have put into the guideline because there is a lot of safety data now, we can reassure them that the risks of untreated disease are worse than the risks of treated disease. Marlena then followed these patients up till they were 12 years old, and these children there was an 8% risk of autism spectrum disease by 12 years old. This is another group that did some similar work and found increased rates of psychological and behavioral disorders in these children. And this is a meta-analysis where they take all of the studies that are available to look at the outcomes of children born to women with hyperemesis. And then they put all of these studies together and determine whether we think that on balance there's an increased risk. And it showed that there was. So, like I mentioned, we don't really understand why these things happen. It could relate to the fact that the children's brains do not develop as well as they might do if they had good nutrient stores in pregnancy. It could relate to the fact that these women are truly miserable and that they have poor bonding experience with the babies. But we're trying to investigate that now. So speaking of the mental health complications, this is really important in hyperemesis. We did a study back in 2021 where we looked at just over 5,000 women with the disease. And the way that this came about was that Professor Williamson, who's my PhD supervisor, had received a grant to look at the genetics of this disorder. And she was invited on the BBC News to talk about it. And as part of this, one of the news respondents had said, gosh, this sounds like a dreadful condition. I've never heard of it. And they said, would you like to work with us together to put together a survey that could go out to the UK population with the help of a charity, the Pregnancy Sickness Support Charity. And so we worked with them together to put together a survey that looked at the lived experience of these women. And we found that 5% terminated a wanted pregnancy because of the disease, and 6.6% experienced regular suicidal ideation. This was at the beginning of the time that I was doing obstetric medicine. I'd largely been an endocrinology registrar at this stage, and I was really struck by these numbers. However, I think it really came to light about 18 months ago when a lady who was normally fit and well, she was a primary school teacher working in the UK, and she was informed by her healthcare professionals over the telephone that she would already have harmed her baby because she was taking an anti-sickness medication. And very, very sadly, she felt she couldn't cope with the risk that she had done this, and she hung herself and was found by her mother in her bedroom later that day. So her family are telling the patient's story, and this has been publicised in the news, in Parliament. But how we respond to these patients, how we treat these patients really does make a difference. They need to feel heard so that they know that we can support them. So when we looked at what the risk factors were for this termination of pregnancy or suicidal ideation, it makes sense that the more vomiting the woman was doing, the more likely they were to have adverse outcomes. Poor functional status, so women that couldn't look after their pre-existing children, women who couldn't hold down a job, were more likely to terminate or have suicidal ideation. But the really sad fact of the matter is that how we treated these patients also made a difference. So in this study, there were 5,071 patients, and we gave them the opportunity at the bottom to open some open box feedback. So they could write at the bottom what their experience was. And just over 5,000 of the women, so 5,017 of the women, had written their experience. So because so many women had responded in this way, we decided that we would do a qualitative analysis where we would draw out some of the themes. So I'll go through some of the quotes that they gave us now. So the way that I've presented this is we went through every comment that the women had made. Professor Williamson and I both looked at each comment individually and tried to draw out the themes that related to physical health, termination of pregnancy, suicidal ideation, for example. And these are the main themes here. In the brackets, it's the number of patients that made a comment related to that. And then the quote is a representative quote of those women. So here you can see that 1,158 women mentioned their physical health as a complication of the disease, being able to see their bones protruding through their skin because they've lost so much weight. And it's when we hear about these cases that we can understand how these women could be so nutritionally deprived that it might affect the baby. 223 women mentioned termination of pregnancy. One woman said, I couldn't take it anymore and asked for termination. It was that or I would have taken my own life because I had nothing left. 65 women mentioned suicidal ideation. I felt scared and alone and attempted suicide when it felt like the only way out. And remember, these women aren't all empowered. Many of them are lying in bed. 70% of these women with severe disease aren't getting out of bed. They become lonely and they feel unheard. Over 1,000 mentioned the quality of care or lack of quality of care that they received. It's very common for women to say, I'm not taken seriously. I had to lose 2 stone of weight before I was taken seriously by a healthcare professional. And I was made to feel like another first-time mother unable to cope. Women feel guilty about taking medications. They feel guilty about suffering with the disease, but they also have the pressures from their family and friends. One woman said, my family accused me of hurting my baby because I was on medication. And also women have their own concerns about medication. And if they have a complication, often find that they blame themselves. So we know that 3 in 100 babies born in the UK will have some form of abnormality. So some of these women will have congenital malformations. But this woman said, I took medication for sickness and my baby was born visually impaired. We do not know whether this was coincidental, but I'll always blame myself. So I think when we're counselling these women, we've got to be so confident that we're talking about medications for which there are so many safety data now. They wouldn't be in the RCOG guidance if we thought that they would cause concerns. And so we have to empower women when they're taking them, that if they do go on to have a pregnancy with an abnormal baby, that they don't carry this guilt throughout the rest of their lives. 386 women mentioned clinical inertia. One said that my GP said I asked my GP about the safety of medications and was advised it was safer to persevere with the symptoms than risk taking medications. And I'm not criticizing GPs here because I know that they look after many patients from many different backgrounds with many different conditions. But as those of us who work within maternity, we have to be able to empower these women that it's okay to go to their GP and ask for these medications. Finally, 359 women said they'd been sterilised because the thought of another pregnancy with HG would terrify them. So, and the women that were really struggling to cope with the perception of the care they were receiving were struggling to access medication. So let's talk a little bit about the management in the last 5 minutes. So we know that these you will be familiar with from the previous RCOG guidance. The only difference is this drug called doxalamine and pyridoxine, which is a combination of an antihistamine and vitamin B6. It's marketed in the UK as Zomvia. The rest of the antihistamines for first line, the medications that you're familiar with second line, and the steroids for third line are all the same. So Zomvia is a licensed drug in pregnancy. It has been used in over 2 million pregnancies worldwide, and there is no suggestion that it can cause harm. In terms of other medication, I just want to talk about 2 common queries that we receive. So the first is that you can only prescribe metoclopramide for 5 days. Now, this is because of a risk of extrapyramidal symptoms. So these are movement disorders that are very, very occasionally seen in women with hyperemesis who take metoclopramide. But I want to remind you that the incidence of this complication is less than 0.2%, and it's most typically seen in women who are receiving the drug intravenously. It happens within 24 to 72 hours of administration. It typically gets better when you stop the drug. If it doesn't, you can use IV bentropamine, which is effective within 5 minutes. So this is a very, very rare complication that happens in patients receiving it IV. So it's a good drug. It's very helpful. It's used as a second-line medication for this reason. But if a woman's on it and they're benefiting from it, we do not recommend stopping it at 5 days. The next question is ondansetron safe in the first trimester of pregnancy? And the answer is yes, it can be used safely in pregnancy, even in the first trimester. The reason that we worry about this is because of an EMA warning that said that there might be increased risks of congenital cardiac malformations and cleft palate. Now, there have been a number of meta-analyses performed, and one of the most recent, which takes all of the literature together, found that 1 in 3 of the big studies found that there may be an association with ondansetron and cleft palate. But what we have to understand is this. The background risk of cleft palate is 11 per 10,000 patients. So 11 per 10,000 babies born in the UK will have evidence of cleft palate. If the association between ondansetron and cleft palate is true, which was found in 1 out of 3 big studies, it increases the risk to 14 per 10,000. So the attributable risk from the ondansetron is 3 per 10,000. Now, I show women this infographic, which you can find in the RCOG guidance and the appendices, because many women who have very severe disease, who are increased risk of all of those things we've talked about, vernika's encephalopathy, VTE, severe mental health complications, on balance, this is a very small risk. When it comes to inpatient management, we've talked about this a little bit, but normal saline is the fluid of choice. Hartmann sometimes is used in day units. We avoid dextrose solution, and it's important that we monitor the electrolytes daily and check for VT prophylaxis. These are the reasons we admit patients. So if they've got dehydration, clinical dehydration, if they're losing significant amounts of weight, and you can find this algorithm in the RCOG Appendix 5. Now, the reason that we've got 3 different types of appendix here is because what we were finding is that if women went to the GP, another woman went to A&E, another woman came to the early pregnancy unit, they were all getting different care. So then when we would see them in hospital, they'd all be on different things and they'd all been told different things. So we've developed these algorithms so that regardless of whether the patient turns up in the GP, in ambulatory care, or in the emergency department, essentially they get the same treatment through an algorithm. And these algorithms have been co-badged with the general practice community, with the Association of Early Pregnancy Units and the Royal College of Emergency Medicine. So I'm going to just finish with 2 busting myths. So the first is that ginger is an effective therapy for this disease. It isn't. Not only is it not effective, but in a survey of women, 50% found that it worsened the reflux disease. So we don't use this for the management of nausea and vomiting in pregnancy. The second and final point that I'm going to make is that ketones are a good measure of hydration. So we will all have heard of women who were denied treatment or access to hospital care because they didn't have enough ketones in their urine. And this is because of a long myth that ketones are a result of dehydration, but this isn't the case. So I'm not going to take you through this entirely, but this is called the Krebs cycle. You might have heard of it from your university days, but it basically shows how we metabolize carbohydrate. So carbohydrate is what we take through our food. So if you think that you haven't got enough carbohydrate, then you can't, what I'm showing you on the right-hand side is the normal metabolism of carbohydrate. So you break down carbohydrate, you make energy to fuel the body. When carbohydrate doesn't exist, we go into this pathway on the left-hand side, and rather than using glucose or sugar from our diet to make our energy, we start to break down fat. And when we break down fat, we produce fatty acids, acetyl-CoA, and any excess acetyl-CoA, so this that isn't used to make energy, results in this waste product called ketones. So ketones have nothing to do with hydration. This isn't about the amount that a woman is drinking, it's about the amount a woman is starving. So that's why when a patient comes into clinic in the morning, you see them in the antenatal clinic and they haven't had their breakfast, you dip their urine and they've got some ketones. They might not be vomiting, they just haven't eaten their breakfast. So we can use them to see how starved a woman is, but bearing in mind that if they manage to eat one biscuit, the ketones will probably clear. So they're not that good a marker of that either. But what we certainly can't do is use them to decide how dehydrated a patient is. So for that reason, we've taken any mention of ketones out of the guidance and they should not be used for hyperemesis clinical practice anymore. Okay, so final slide. I hope that I've persuaded you that untreated HG carries a risk of morbidity and mortality for both the mother and fetus. We all share the responsibility for identifying and treating these women properly. The guideline recommendations are safe in pregnancy on balance of risk and benefit, and there are many unanswered questions around the pathophysiology and the long-term consequences for these children that we're trying to answer. I'm going to stop there, Trudy, and I'm happy to take any questions.
Oh, thanks so much, Melanie. That was such an excellent talk. I was really struck by the mental health impact of HG, and I'm really pleased to see the diagnostic criteria broaden and include the impact on women's lives and their everyday. There are a couple of questions that have come through. How quickly does biochemical thyroxetosis resolve? When should you take the blood test for thyroid function tests?
I would, if I thought that it related to the hyperemesis and there weren't any other features that I was concerned about. So say the woman doesn't have a good family history of thyroid disease, they haven't got any of the other features, they're not tremulous, having palpitations with eye changes, I would repeat them after 4 weeks. But in that time, make sure that the woman was treated properly.
Great. And a couple of other questions. Is there pushback for GPs to prescribe Zonthia?
I don't think there is a pushback for GPs in terms of prescribing the drug in itself. It's expensive. So I think that if they have a choice, they would choose one of the other first-line anti-sickness medications, all of which are completely acceptable. So I think that, yes, on balance of finances, probably there may be a little bit of pushback, but I don't think it comes from a point of not wanting to prescribe the drug, but rather there are drugs that are cheaper in the UK that are as effective, I think.
Okay. All right. And then we've got one more question. Previous research post-war, should children of NES generation also small? Is this true for HG? I'm not sure if you know of any post-war research around
post-war research.
Yeah,
there isn't around hyperemesis, but there is famine data from both the Dutch and Chinese famine, which of course were war periods. And they're the studies that have actually informed our thinking around the fact that these women are malnourished. Because what happened in those famines is that the women were starved, usually in the first trimester, and they had less than 500 calories for 6, 7, 8, 9 weeks during the war. Now, children that were born to those women are now 50, 60 years old, and they have the same adverse outcomes as the children born to women with hyperemesis. They were born small, they have increased risk of neurodevelopmental and metabolic risk. So that's why we think that it's very likely that these babies are being exposed to a malnutrition in the womb. So it's a good question, and it is informing what we're doing. But hopefully by the end of my PhD, I'll be able to tell you the answer.
Okay, that's fantastic. And just very quickly, there appears to be a current Pabrinex shortage. Is there an alternative to prescribe?
Yeah, so we're using vitamin B complex. I'm happy for people to email me. I can put my email in the chat. I can't remember the exact dose and the name of the new complex that we've got available. But you can either give oral thiamine if the patient's able to keep anything down, which doesn't taste very nice, so I think isn't very popular. But yes, there is a different solution that we are using. I'm sorry, I can't remember it off the top of my head. But I'll put my email in the chat, and whoever's asked the question, I'll write back, or I'll write it in the chat later today so that people can see.
Oh, that's fantastic. Yeah, and if there are any other questions, if you wouldn't mind taking some of those via email, that would be excellent. Thanks so much. That was a brilliant talk. Thanks a lot.